So now moving from the head to spinal cord injuries. Now, remember the cervical vertebrae, thoracic vertebrae, lumbar, sacrum, and coccyx. I want you guys to review some of the spinal cord. I want you to remember that there is the transverse process. And then we also have the spinous process that comes down. There is the vertebral body, then the vertebral column, and we also have the lateral or transverse foramen, where nerves exit out laterally from the spinal cord. Now, most of these spinal cord injuries that we're talking about is through the central spinal cord. This is down through the central spinal os, that opening inside the spinal cord. Now, the spinal cord usually runs all the way up from the base of the brain, and it goes all the way down to about L2, L1, L2, where then the spinal cord then transitions from the that terminal ending into the cauda eguina. All right. I hope I said L2. No. All right. So this is where we're looking. So now anywhere from the C3, 4, 5, if we fracture anything in that range or higher, we are looking at potentially affecting what nerve, that affects what part of the respiratory, what is the largest respiratory muscle, and the person may be, that's correct, so it's going to affect the phrenic nerve, 3, 4, 5, and we're going to be affecting the diaphragm, and the person might not be breathing, so we'd have to breathe for them. This is usually a result of some type of whiplashing kind of injury, as well as axial loading, so it can directly compress the spinal cord from head on down or from tail on up, or just kind of like twisting and waxing motion. So just knowing the mechanism of injury can give us an idea of how what type of injuries may occur. Now remember, in the cervical vertebrae we have some foramen that run up through the vertebral body, and these house the vertebral arteries, and they supply blood flow to the. Now, if we have this type of whiplashing or serious whiplashing and rotation of the cervical vertebrae, we may have lacerations or occlusions and dissections of those vertebral arteries. Not to mention that we can have some dislocations, subluxations, or movements of and fractures of the vertebral body, or movement of the entire spinal cord moving towards and then causing compression on the spinal cord through the spinal canal. All right, so there's many other smaller ideas of the injuries, spinal cord injuries, compressive spinal cord injury itself, where it compresses the the spinal cord that runs inside the spinal canal. We can have cord compression, which is similar. It can cause, because of displacement of the vertebral body or misalignment of the vertebral column. It can be contused, it can be compressed, it can be concussed. These are just all types of injuries that can happen to the spinal cord. We would then check the dermal tones, and we do a good neuro exam. Depending on how high up we think the injury is, it may require us to do cranial. It may require that special test of the cranial nerves, or it may require us to work our way further down, doing more of our PMS, and then you're noting the strength of the muscles and the temperature sensation and ability to sense these nerve sensations. Complete transections usually lead us into some kind of quadriplegia, and it all depends on where in the body. Below T1, we look at paraplegics. Above T1, we look at maybe quadriplegics. This means that both sides of the body bilaterally are now paralyzed, paresthesias, paresis. Incomplete cord transections. We talked a little about anterior cord, central cord, and bouncing cord. These depend on what part of the spinal cord. Remember, I told you that the nerves that transmit themselves on the anterior surface of the spinal cord, they are more for motor, and the posterior ones are more for sensory. So if we look at these tracts being compressed and they cross over, right, they decussate. So if you injure the front part of the spinal cord, I may have injuries that affect motor movement if I compress injuries on the back. I may have injuries with sensation if I compress from right to left. I may have compression where I have sensory and motor dysfunction. So think about those as we talk about it. There may be also injuries that are not seen on radiographic findings. These are called spinal cord injuries without radiographic abnormalities, SIWORA. So we definitely want to treat our patients more so with the mechanism of injury, because we won't be able to do these type of radiological tests or studies out in the field. Another type of injury that we want to worry about besides the spinal cord is the distal end of the spinal cord as it comes out of L2. 3, it's known as the Conus Medullaris, and then we have the cauda eguina. Cauda eguina is the nerves that innervate all of the pelvic regions. That includes the bladder and reproductive organs. And so what will happen is they'll have this saddle paralysis or saddle anesthesia, which is anything that you would sit down on a bicycle or a saddle. If that's all numb, we have areas that are injured, and that injury is to the cauda eguina, and this can cause the bladder to retain fluid. And so we really want to take a good account of our patients as we do our assessments. As far as treatment goes, manual inline immobilization. Manual immobilization first. Determine the rest of your life threats. Go ahead and treat your airway, breathing, circulation. Once you decide that you're going to use some type of spinal immobilization or spinal precaution or spinal management precaution, then decide what you're going to do. Do your good neurological exam. I always try to say it, start off with some of the cranial nerves, pupils response at least, whether or not they can smile, whether or not they can remember, say their name, date, and place. Those orientation questions, they help to tell you whether or not they're breathing well, whether their cranial nerves 7 and 9, whether or not they have blood flow going to their brain so that they're maintaining well, watching whether their eyes move back and forth and they can track you, whether they have good vision, whether they can hear, whether their face is symmetrical. We're getting a lot of your cranial nerves. Then when you ask them to squeeze your fingers, when you're doing your upper and lower extremity checks for pulse, motor, and sensory, you're testing some of the accessory movements as well as nerve and motor and blood vessel distribution as it comes out to the extremities. So just do a good spinal cord examination if you think there's a spinal cord injury. Now again, dermatomes. About 4 is nipple line. As we come down to the xiphoid process, we got about 6. We look at the first part of the rib cage as it runs out, the hypochondrial region, and we got about 8. When we come around the lower rib cage, just under the hypochondria on your lateral flanks, we got about 10. And as it comes down, that's 8. As it comes down across the umbilical, we got distribution, dermatome 10. And then on the top of our your hips, the iliac crest, you got your dermatome 12. And so somewhere around just below that iliac crest is your lumbar vertebrae, and that's L2, what comes out of L2. Great. And so where are the cervical nerves radiating out of the neck, coming down? They're innervating the upper extremity, upper arm, come across the forearms. We're looking at the thumb, the 2 first fingers, the last 2 fingers, and then we have the first thoracic running along the base of the ulnar.